Hello everyone, welcome to our YouTube channel Dr. Arthro. This video is about arthroscopic repair of rotator cuff tear. The arthroscope is introduced into the joint via posterior portal and a complete intra-articular examination is performed by 15-point SCOI system. An anterior rotator interval portal is created to allow surgeon to carefully examine the intra-articular structures with an arthroscopic probe. Let's proceed in respect to the case. As you can see, the biceps tendon is frayed and degenerated. It's also essential to look at the distal part of the tendon. As you can see, the biceps tendon is being probed using anterosuperior portal. The goal is to bring the distal part of the tendon into the visual area and inspect for the pathology. We're going to tenotomize the diseased long head of the biceps tendon using the radiofrequency ablator. The tenotomy is done on the inferior aspect first and then is completed from the superior aspect. And we have to make sure that all part of the tendon is chopped out. The rotator cuff tear is inspected from the articular side and assessed for the size of the tear. The arthroscope is withdrawn from the posterior portal now and is inserted into the posterolateral portal. It's easy to assess the tear size and shape using the direct lateral portal twist in 8.25 mm arthrex cannula is passed, which acts as a gateway for radiofrequency ablator. The subacromial decompression is started now. Once inside the subacromial space, the ablator creates better exposure after release. The ablator is used to denude the undersurface of acromion so that burr can be used effectively to remove the part of the bone. The burr is inserted from the lateral portal and is used to do the acromioplasty. The burr is moved from anterior to posterior in a rhythmic motion. Around 3 to 4 mm of undersurface of acromion is removed. The thickness of burr is almost the amount of thickness of the bone we would like to remove. In order to achieve the good visualization, it is recommended to have constant inflow of water and the outflow of the water is maintained as well. The ablator is also used to coagulate the bleeders occurred after acromioplasty. Good visualization can be achieved by intermediate cauterization of the bleeding area. So in the last phase of subacromial decompression, the burr and the ablator are used alternatively to maintain a good bloodless area. Rotator cuff footprint prepared. After removing residual torn tissue and scar from the exposed footprint, the goal is to reduce the trim lateral edge of the tendon to the chondral margin with minimal tension. If this is not possible with minimum tension, it is necessary to perform both bursal and articular side releases of the rotator cuff in order to improve the excursion. The greater tuberosity is then debrided of soft tissue such that cortical bone is exposed. The needle can also be used to assess the location of the tear. Grasper can be used to assess the tension to judge if any further release is required. In some cases, traction sutures can be applied to reduce the tendon to the bone while passing sutures through the tendon. First, the needle is passed using the express screw to pass the fiber wire to the tendon, and then it is taken out through the anterolateral portal. Medial ankle placement is just lateral to the condyle junction. Over the footprint area, the punch is used to make a hole for medial row suture anchor. The punch needs to hammer till the mark. To maximize the pull-out strength, the suture anchor should be placed at 45-degree angle to the bone, also known as dead man's angle. Helicoil 4.75 can be used for medial row. It's double ultra braid suture with blue and white color. The ultra braid suture can be delivered one at a time after the lateral portal through the plastic cannula. The suture is loaded on the express sieve, the suture passer, and then sutures are passed through the tendon at the appropriate interval to cover the thickness of the tear. After passing through the tendon, the sutures are delivered to the anterior or posterior portal. In the next step, Two sutures of the same color are delivered through the lateral portal. Arthroscopic nodes are tied over the ultra-braid sutures once the tendon is reduced well. The helical PK suture anchor differs from the conventional solid core implants by eliminating the inner diameter material. This allows for the bone growth within the anchor thread profile, providing excellent fixation and security. Even with a reduced volume of material, this anchor provides a superior level of biomechanical performance the surgeons can have real confidence in. At last, the lateral row site is prepared using radiofrequency ablator and following standard steps of suture anchor placement. 4.75 civil lock is inserted and the suture ends are cut. The civil lock product line consists of fully threaded twist-in knotless anchors designed for its use with fiber wire, fiber tape, and soft tissue grafts in repair and reconstruction techniques. Tension is visualized, adjusted, and locked into the position with swivel lock anchor body. Swivel locks are cannulated and vented to minimize the material. The ankles are available in bioabsorbable biocomposite or PLLA and non-bioabsorbable PEEK or titanium materials. although in this case we have used one medial row and one lateral row. Anchor. Often the tears require two medial row and one lateral row suture anchors. Thank you very much. This finishes this video. I hope you enjoyed it. If you like this video, don't forget to subscribe our channel. Thank you very much.